Testing, testing. Morning. Today we're gonna see a robotic hysterectomy. We're using the Da Vinci XI system. We can see here the patient has history of abnormal bleeding. Some of the settings that I change here, first of all, you have to log in. Then you have some of your settings already applied. Then you choose what type of surgery you're doing. Then you choose energy controls, where I use a bipolar on 6. And then we go and choose the hand controls to quick. Hello, Mark. So this is a patient with history of abnormal bleeding. You can see here the left fallopian tube, the right fallopian tube with erectable cyst. Usually these cysts are benign. So you can see underneath the ovary that has a simple cyst. So we're getting the right fallopian tube with a bipolar instrument. Now we're getting the two ovarian ligament. This is the ovarian ligament, the one that I have in between the bipolar instrument. This is the round ligament. So we have the round ligament on the right side. Underneath is the ovarian artery, the one that I have right now on my bipolar instrument. Now we're getting into the broad ligament. We open the broad ligament to expose the artery and vein. This is an implant of endometriosis. Both of these instruments are bipolar. So we're exposing right here the uterine artery and the uterine vein by opening the broad ligament. This is the posterior view of the broad ligament. Here we can see the vein, the uterine vein. Here is the uterine artery right there. You can see pumping the uterine artery right here underneath. Have to make sure that we get the uterine artery before transecting it right here. You can see here some of the lesions. This patient had a history of prior C-sections. You can see some of the lesions on the bladder to the anterior uterine wall. Now we're getting the uterine artery with a bipolar instrument, but to make sure that it's hemostatic before transecting. Right here is the uterine artery. So we have to get first the uterine artery and the uterine vein, have good hemostasis before transecting. We're getting here the right side of the bundle. We're probably at the level of the hysterectomy ligament right here. The other side. Now we're getting the left side of the uterus. Now we're getting the left fallopian tube. The left fallopian tube on the left side. Now, as you are underneath the left fallopian tube with a bipolar instrument, this is called the vesicular. It's a bipolar instrument that coagulates and transects. That's a physical blade, and you have coagulation that you can transect with the instrument, getting all the way to the ovarian ligament. There's some adhesions here in the ovary. And the sigmoid, we're going to release all the patients, and all the patients. We have to be careful because sometimes there's diverticulum in the sigmoid. I'm not saying these are diverticulums, but you have to be careful on older patients because you can find diverticulums attached to the ovary or to the uterus. Now we're getting the ovarian ligament. You can see here some endometriosis in the left pelvic sidewall. Now we're getting the broad ligament on the left side. We're doing the same procedure that on the left side. We're opening the posterior left, the anterior and the posterior left of the broad ligament to expose the veins, the artery in the vein. Now we're exposing the posterior lip of the broad ligament so we can see the uterine artery. Usually the uterine artery will run posterior to the vein, so we have to open the posterior left of the broad ligament to expose more of the artery in the vein. You can see here the vein and the artery. We're opening the posterior left of the broad ligament. Then you have to be very careful and very easy to lacerate the vein, but it's not a big deal. But we want to have clean surgery. But you can see here the artery and the vein bundle. Grab it with the right corner instrument. Again, my settings on the right corner instrument is 6. Secure these veins and artery. Before constructing, make sure that we have good hemostasis here. And sometimes the uterine artery coils back here. You can see here, this is a hysterectomy ligament right there. Scissors. Now we got the uterine artery on the left side, the uterine artery on the right side. They are going to perform the colpotomy anteriorly to the right side. The colpotomy anteriorly, and then going to the left side. There's not a lot of additions to the anterior cervical wall or uterine wall because some patients require history of hysterectomy. It's not uncommon that we see here the bladder very close. In this case, I don't see it. That's already diagen and mucosa. We're going to open with the unipolar scissors. If you remember, I put the watts to 5 on the quad, and I go coagulating in this part of the hysterotomy. You can go cut, but because we don't have the same hemostasis as we go on coagulation. Have to be here sure that we get the uterine artery. Don't push too much. Right. We have to release here the tension so we don't have retraction of the vessels and then we have some bleeding. So it's important not to put too much traction. And we go posterior. To the level of the uterine sacral on the right side. Then I put my camera away, and then we go to the anterior lip. open here, hysterectomy, anterior and posterior. Deliver the uterus vaginally. So be careful here in the back of the uterus with a valve. Suture. Now the next step is to suture the hysterectomy, the vaginal. All we use two sutures. Stratafix. It's an absorbable suture, bar suture. Now we're suturing the hysterectomy starting on the left side of the patient, getting the angle. Again, this is a bar suture. It's called Stratafix. 6 inches. It lasts for, probably say 3 months. It's an absorbable suture. I think one of the important things here on the closure of the vaginal cuff is getting the angle. Getting the angles is very important. So with this suture, you basically you're going to get the left angle of the vaginal cuff. You be sure also to incorporate the uterosacral ligament and the suture. You can see the uterosacral ligament, put it together. This is important because the uterosacral ligament is one of the ligaments that maintain the axis of the vagina. So we got the angle for sure. So at this point we finish most of the procedure. Now is the closure of the vagina. Usually straightforward hysterectomy will take you between 20 to 30 minutes to finish, from start to finish. Usually these patients will go home after 3 to 4 hours in recovery. 3 to 4 hours after the surgery, they have a trial of voiding. I placed a Foley during the surgery and remove the Foley immediately after the procedure. So when they're asleep still, so they go to the recovery room without Foley. And then when they recover from anesthesia, they go to the bathroom, pain is controlled and everything as well. They go home the same day. And with ibuprofen and Motrin for pain, and some pills of Tylenol 3, if they have more pain than normal. I would say 50% of patients will take only the Motrin without taking camel tail that has coating. So we here have a second suture to close the right side of the vaginal cuff. We use the same suture, or we use Stratafix, 6 inches. The Stratafix is a butter suture, absorbable. So you get here the angle of the suture, of the vagina. And then incorporating the hysterectomy ligament on the left side. This is important because, like I said before, the hysterectomy ligament is one of the ligaments that maintains the axis of the vagina. So, by cutting this ligament and put it together, we prevent prolapses in the future. So I think that's an important step on the hysterectomy. Well, this point with me is a procedure. Again, this is an outpatient procedure. Patients will stay in the recovery room for a few hours, usually 3 hours, 4 hours. When they wake up, we see that the pain is well controlled, that they're able to void, and then they go home. They have a follow-up in 2 weeks. Straightforward hysterectomy. It will take you between 20 to 30 minutes to finish. Minimal bleeding is important. Some patients will have a history of irregular periods, so they already have the anemia, so you don't want them to bleed more during the surgery. If you have any questions, you can put them on the comments below. Try to answer them. Appreciate it for subscribing to the channel. And we'll see in the next case. It's going to be a endometriosis. Patients with pelvic pain. At this point we finish the procedure. We're removing the sutures. And can I irrigate to remove those clots from the pelvis? I like to not leave any type of bleeding or clots in the pelvis because that prevents a lot of adhesions. Also use the anesthetic agent in finishing the procedure. So thank you for watching. register and subscribe to my channel, and we'll see you in the next one.